and gram-negative diplobacilli like Moraxella. There is a lot of difference between microbial keratitis and contact lens-induced peripheral ulcers, especially here that you can see the CLPUs are small, they don't have an overlying epithelial defect, and the edema is localized to the area of the infiltrate and spontaneous resolution after removing the contact lens. Decreased corneal sensation, corneal decompensation, epithelial defect, prolonged use of corticosteroids, topical anesthetic abuse, and chronic use of broad-spectrum antibiotics are also risk factors for microbial keratitis. Diabetes, AIDS, SJS, burns, comatose patients, and also those with connective tissue disorders, and Moraxella with alcoholics and debilitated patients. Eyelid diseases like blepharitis, and also dacryocystitis, ectropion, entropion, and lag ophthalmos can be risk factors. A detailed history is important. External examination, appearance of the patient's skin condition, facial examination, eyelid, slit closure, NLD, and corneal sensation must be assessed prior to installation of topical anesthesia. Eyelids, lacrimal sac to rule out dacryocystitis, looking at the conjunctiva for discharge, associated conjunctivitis, circumciliary congestion, type of discharge, mucopurulent and bacterial, greenish in Pseudomonas, precorneal tear film. The tear film will have numerous debris. And also you can look at the differentiation between conjunctival and ciliary congestion. The size, shape, location, depth of the corneal ulcer should be examined. The location should be marked schematically. It may be central, paracentral. Central ulcers will lead to poor vision, especially in Staphylococcus and Pseudomonas. Paracentral, like Staph, Pseudomonas, and Fusarium keratitis. Mycobacterium may typically cause peripheral ulcers. Ring-shaped ulcers may be seen in Acanthamoeba, Staphylococcus, Pseudomonas, and fungal. Oval ulcers are seen in neurotrophic. The margins are also important. Healing ulcers have well-defined slopy margins. Active ulcers have ragged margins. Well-defined ulcers could be a healing infectious ulcer, punched out in a neurotrophic, indistinct in a progressive ulcer, overhanging in Murren's ulcer, hyphate and feathery margins in fungal ulcer. Viral keratitis, we are not really, we are only concentrating more on bacterial keratitis. Viral is mostly a clinical diagnosis. Here you can see a dendritic ulcer. Here you can see a disciform ulcer. Here also you can see corneal edema. These cannot be mistaken for anything else other than viral keratitis. Neurotrophic ulcer, you can see where, oval shape of the ulcer, heaped up margins, and decreased sensations. The size of the ulcer is also important for follow-up and monitoring progress. Epithelial defect and size of infiltration should be measured in two largest meridians. In case of corneal abscess, the epithelium may be intact over the infiltration. Rose Bengal or fluorescent staining can be used when necessary. Area of epithelial edema. Infiltration may be single or multiple. Corneal sensations have also to be measured. Base depth and pigmentation should be noted. Superficial and deep vascularization should also be noted. The grading of the ulcer is mild, moderate, and severe, less than 2 mm, 2 to 5 mm, and more than 5 mm. And depth of the ulcer is more than 50% in severe ulcers. And dense infiltrate is also seen in severe ulcers. Scleral involvement may also be seen. The anterior chamber reaction should be seen. Mobile hypopion is seen in bacterial keratitis. Synechiae, rubeosis iridis, iridocorneal plug can also be noted. Pupil and lens size and reaction, and lens of visible for cataractus changes. Scleral involvement warrants the use of IV antibiotics. Posterior segment of visible or ultrasound B scan has to be done. IOP in case of desmetocele, never assessed digitally. Lacrimal apparatus, and systemically the fasting and post-lunch blood sugar. Documentation, slit lamp photography has to be done meticulously. And here you can see the various kinds of documentation, and you can see that as the infiltrate heals, you can see the grayish area as the healing infiltrate. Clinico-microbiological correlation. Pseudomonas ulcers are seen in contact lens users and hospitalized patients with a marked mucopurulent exudate. Pigment fluoresces under UV light. Ring infiltrate, dense hypopion. Suppuration can lead to perforation. Dense yellow, gray or gray white infiltrate with overlying epithelial defect, mucopurulent exudate, multiple infiltrates, and especially when it's polymicrobial or there is foreign body or in a contact lens user. This was one patient who had Pseudomonas keratitis, and here you can see the infiltrate and a mobile hypopion. So on healing, you can see that she's scarred, so you have to document. This is another case of Pseudomonas keratitis with corneal melt. Streptococcus pneumonia is a focal infiltrate, serpiginous edge, may move rapidly. There could be stromal edema, DM folds, may have endothelial plaque, severe iritis. And here there is one in the graft host junction and another when there is a suture infiltrate. Staphylococcus aureus, well-defined, white gray, creamy. There could be PED. It may be due to prolonged use of steroids, multiple opacities, may enlarge circumferentially, may form an abscess. So here you can see staphylococcal infiltrates. Acanthamoeba keratitis, this is courtesy Dr. Paras. This is a ring infiltrate, appears in a pretty late stage. It could be a plaque-like presentation. It could be a persistent epithelial defect like that in this lady with an agricultural background. Scraping showed acanthamoeba cyst, and you can see that there is peripherally a healing edge, and though there was a lot of scarring on healing, the patient did recover some amount of visual acuity. Here you can see SPKs and pseudodendrite-like presentation in a CL user who used tap water to clean his lenses. Here is another patient who was a farmer and who had a ring infiltrate with hypopion, and he needed therapeutic keratoplasty. Microsporidia can be, it could be a epithelial disease, or it could be a stromal disease, or there could be an ICK also in microsporidia. Here you can see raised stuck-on SPKs. Nocardia, you can see peripheral pinhead-shaped dots, which is filamentous beaded bacilli you can see on scraping. Fungal keratitis, traditionally known as dry infiltrates, and here you can see various kinds. Here in a contact lens user, you can see two infiltrates with a satellite lesion. Here was another patient who presented like this with a large fungal keratitis. So here you can see a pigmented fungus, curvularia here. Another hyphate edges typically could be mistaken for dendrites. Another case of pigmented fungus. Here you can see this is an iris prolapse, but here there is pigmentation. So fungi can be septate, non-septate. There could be yeast, pigmented fungi. You can see that there can be various kind of presentation with fungal keratitis. So all these, and you can see it in confocal microscopy also, which we will discuss later. The other things that I wanted to show here was, I'll just take a minute extra. This was a patient who had polymicrobial keratitis. So when she did not use her antifungal, the infiltrate actually increased. But when antibacterial antifungal were used, she scarred. Another case which I had shown earlier, which is the plaque acanthamoeba with fungal keratitis. A third case of nocardia with pseudomonas in a contact lens user. This is important. Here you can see a patient who was treated on antifungal but had broad sparsely septate hyphae, worsened with antifungal, and topical linezolid with azithromycin. She showed improvement, so it was pythium keratitis, where you can see this tentacles, guttering, that is very important to note. And also in a similar patient who was mistaken for fungal keratitis, showed broad aseptate filaments, and it resolved finally. This was another case of pythium keratitis. So another case where there was fungal keratitis, also there was Proteus, he needed therapeutic keratoplasty. Another patient where there was atypical mycobacteria with coagulase negative staphylococcus, and it took at least 8 months to heal. Thank you for your kind attention. The next talk will be by Dr. Charu Tandon on how to diagnose in the laboratory.
Good morning, everybody. I'll be talking on corneal scraping and microbiological workup. The management of microbial keratitis requires corneal scraping for smear and culture. Scraping is the superficial keratectomy procedure to procure samples from central infiltrates and any infiltrate more than 2 millimeter in size. Even in settings with limited or no lab facilities like the primary health centers, microscopy may provide valuable information to guide the clinician in their choice of treatment. The microbiological workup of corneal ulcers includes specimen collection, staining and culture, lab analysis, and antibiotic susceptibility testing. The general principles are, if possible, withdraw the use of antimicrobial for at least 24 hours. Where this is not possible, you use a liquid phase media like brain heart infusion, which serves as a diluent that reduces the concentration of the antibiotic below the MIC. We apply anesthetic drops that do not contain preservatives. Use different blade to take each sample, and if Chimera scalpel is used, flame the scalpel between the samples. If fungal and amoebic infection is suspected, it is preferable to take the sample material from deeper stromal layers of the cornea. The order of specimen preparation, you usually make a slide for KOH mount, gram stain, Gimsa stain, and alternative staining procedures are taken up if required. Solid phase media like blood agar, chocolate agar, Savarez extras agar, and non-nutrient agar with E. coli overlay are used. Liquid phase media, brain heart infusion, thioglycolate broth are used. If the ulcer is very discrete or very small amount of material is available, we inoculate one solid and one liquid phase media. So the specimen is collected under slit lamp magnification under topical anesthesia. Proparacaine hydrochloride 0.5% is preferred because of its minimal inhibitory effect on organism recovery. The corneal material obtained is taken from the advancing borders and the base of the infected area. Specimens obtained are ideally to be inoculated onto the immediately onto the appropriate culture media. If not feasible, then it should be placed in a broth culture prior to transportation. Extremely important to properly document, that is diagram and take a photograph of the ulcer before scraping. Explain the procedure to the patient and use proper instrumentation. Important to make the patient comfortable by using appropriate anesthesia and reassure the patient. For the collection of sample in the correct manner, we remove the debris and the purulent material with bud and discard. Scrap the base and the edges of the infiltrate. Mild to moderate pressure with blade perpendicular to the surface of the cornea and multiple strokes in single direction. We avoid the areas of thinning and never use the tip of the blade. So transfer the sample to the glass site for direct smears. We use sterile glass slides pre-marked with glass pencil on the undersurface in the center of the slide. Ensure that the marked slide has an identification number and name. So make an ideal smear. So for gram stain, the smear should be as thin as possible. For KOH wet mount, smear in the center of the slide, place 1 drop of freshly prepared 10% KOH and immediately cover with the cover slip. For identification of fungi, calcifer white can be used if you have access to a fluorescent microscope. Additional smears like Gimsa and acid fast smears are taken when necessary. In special situations like uncooperative patients, you can plan the procedure under local anesthesia. In very uncooperative and pediatric patients, you can even take them under general anesthesia. If there's an associated desmotocele, you avoid scraping, and if absolutely necessary, you take them under local anesthesia. So if required, you can use a tissue glue and bandage contact lens if required. For deep-seated infiltrate, skin biopsy punch or trephine may be used to take the specimen. You cut the specimen into half, send half for microscopy and half for histopathology. Alternatively, you can lift a flap and take the scraping from the base, and you can reposition the flap by using glue. So then staining of the specimen helps in broad categorization of the pathogen. The smear is applied to the clean slide as said in a thin layer. The fixation is preferably done with methylone 95% or cold acetone, or otherwise you can heat fix it. Commonly used stains, as I said, are grams, Gimsa, acid fast. PAS, GMS can also be used to identify fungi. Acanthamoeba can be identified with calcifer white, acridine orange, PAS, H&E, even with grams and Gimsa. So for gram stain, which is most commonly used, sensitivity is 55 to 79%. can be used to distinguish bacteria from fungi also. And gram-positive bacteria appear bluish purple, while gram-negative appear pink. So the specimen is first, the crystal violet is applied for a minute, then it is rinsed, then iodine is added, which acts as a mordant, and then it is decolorized with an alcohol wash. The counter staining is done with safranin or dilute carbol fusion. So this we have already discussed, the bacteria, and this is gram-positive cocci in pairs, diplococci. Here gram-negative, gram-positive cocci in pairs are seen here, and here gram-positive cocci are seen in clusters. Gram-negative bacilli, most commonly it's Pseudomonas, which is the causative organism in keratitis. Here gram stain showing Acanthamoeba cis. The acid-fast Z. Nielsen stain, so you use primary staining with strong carbol fusion is done for 30 seconds. You heat it, so heat fix the slide, and then decolorization is done with acid alcohol for 15 to 20 seconds, and then counter staining is done with methylene blue. Here first the 1% alcohol is used, and 20% is done in a second sitting. So here beaded filamentous bacilli are seen. If these are seen with only 1% acid-fast staining, it is typical of Nocardia species, and if they stain with 1% and 2%, then Mycobacteria is likely to be the causative organism. This is branching gram-positive and variably acid-fast Nocardia, and the second slide is showing Mycobacterium stained pink with acid-fast staining. For KOH wet mount, you freshly prepare 10% KOH, put 1 drop on the specimen, you place the cover slip. First you observe under 5x. Now this observation is done in dark field, so your shutter is closed and the condenser is is in the lower position, and then you observe under 40x. So this is how the fungal hyphae are seen in KOH. The lower slides show gram staining and Giemsa of the fungal hyphae. So the fungal hyphae here seen in KOH, and in sabirids you can even identify the species or depending upon the growth on the sabirids or the pigmentation on the growth. Also the pigmentation on the back side of the bottle gives you an indication to the species. Otherwise, from the culture, the smear is taken and stained with lactophenol cotton blue, and the morphology of the spores gives you the species identification. This is GMS staining of the fungal hyphae and calcophore white under fluorescent microscopy. These are Acanthamoeba cis. This is gram stain showing budding yeast indicative of Candida species. Plating on the culture media. While plating, the specimen should be inoculated in C streaks to distinguish valid bacterial growth from plating contamination. The aerobic bacteria to be kept for 7 days before reporting no growth, and anaerobes for 7 to 14 days. Microbacterial and fungal culture should be held for 4 to 6 weeks before reported as no growth. So basically each sample to be taken separately with a new blade, and the blade to be discarded immediately after taking the sample. So for inoculating the culture media, gently smear with C streaking, making sure not to puncture the surface of the agar. Seal the plate and incubate the media as soon as possible. Refrigeration should be totally avoided, and even if there is a gap between transfer to the lab, the samples should be kept at room temperature. This is C streaks showing growth. Here you can see that there's a contamination also. For culture media, so fungi acanthamoeba can be recovered from blood agar. For acanthamoeba, buffered charcoal yeast extract or non-nutrient agar with E. coli overlay is there. For fungal keratitis, sheep blood agar, chocolate agar, Sabaris dextrus agar, thioglycolate broth is used. Initial growth occurs within 72 hours in 83% of the cultures and within 1 week of 97% of the cultures. The culture media can be made more selective for isolation of fungi by adding antibacterials like gentamicin and chloramphenicol. So for bacterial culture, the diagnostic criteria is same organism growing at the site of inoculation on 2 or more solid phase culture, or growth at the site of inoculation in one solid phase media of the organism consistent with the microscopic findings, and or otherwise a confluent growth on one media. Diagnostic criteria for fungal specimens: the fungal hyphae observed on corneal specimen, on microscopic organism, or growth at the site of inoculation of the solid culture media. The other so culture positive rates may be low because of prior use of antibiotics and antifungals and deep-seated lesion, inadequate samples, and improper inoculation techniques. In addition to corneal scraping, foreign body embedded in the infiltrate, loose sutures, and contact lens solution should also be sent. And these are the antibiotic sensitivity discs that are used. Confocal microscopy can be used, and corneal biopsy for non-responding deep ulcers can be taken. Based on the sphere, the antibiotics are given, and these are the various media available and the duration for which they should be kept ideally before labeling a sample negative. Thank you.
Thank you, Dr. Charu, for that extensive on how to diagnose a corneal ulcer. Now that we have identified the organism clinically and done the microbacterial, and we have also started treatment, some of them unfortunately may perforate. How to handle this will be explained by Dr. Paras Mehta, who has got an experience in cornea diagnosis and treatment, and she's an excellent surgeon for more than 25 years of her cornea practice. So over to Dr. Paras Mehta.
Good morning, everyone. After listening, is it connected? After listening to the previous two talks, we would be looking at use of cyanoacrylate tissue adhesive antennas patch graft in cases of if we encounter a corneal perforation in these microbial keratitis. So infectious keratitis is one of the commonest cause of uniocular blindness across the world. Every year an estimated 1.5 to 2 million people lose their vision as a consequence to microbial keratitis across the globe. Severe stromal thinning in cases of microbial keratitis can result in significant ocular morbidity, and recalcitrant cases can often result in corneal perforation. Such cases are considered as an ophthalmic emergency and may require urgent intervention to maintain the globe integrity. I'm sure every one of you must have faced this kind of situation in your clinical practice in your OPD. So failure to do so may result in catastrophic sequelae such as endophthalmitis, suprachoroidal hemorrhage, vision loss, or at times eye loss of an eye. The goal of treatment of corneal perforation is to restore the eyeball integrity and enable appropriate healing to occur so that a corneal transplantation or any other surgical procedure can be performed to regain the vision in those eyes. For a clinician to handle infectious keratitis is a challenge. Sometimes even if you are treating the infection and it is responding, they may end up into a corneal perforation. As you can see here, this patient sustained hair injury into the eye. The child was sitting in the lap of a patient and the hairs brushed against the cornea accidentally when they were traveling on a two-wheeler. As you can see here, this is not a very classical presentation, but you can see that multiple small infiltrates are there and there is a ring kind of an infiltrate occurring. On the first scrapings, we found out that there were gram-positive cocci, and we started treating this patient on antibacterial management. But as you see on follow-ups, this patient worsened further. So as Dr. Uma was alluding upon, many a times we may deal with more than one organism, and probably this was in addition to a bacteria, there were fungal elements also. So you have to add. So it is very important to even scrape these patients in between. You can see that now the patient has started responding to antifungal management, and this is how it responded, and eventually the patient healed with a corneal scar, but it does not happen every time. This is another patient where we found out that there was a fungal infection which started responding to antifungal management, but on the next follow-up you can see that the patient ended up with a corneal perforation. So what are the options for such situation when we see these patients like this on a follow-up? So we have various surgical options available. One is if the perforation is small, microperforation less than 2 millimeter or with a non-necrotic base, or you can go ahead and do a tissue adhesive application with a bandage contact lens application. One can also resort to a partial tarsorrhaphy when there is surface infection, persistent epithelial defect, or a non-healing kind of a defect. One can even use amniotic membrane grafts if there is a PED, or one can use a T-nons patch graft if perforation size is more than 2 to 3 millimeter. If the size is, one can also even resort to conjunctival graft or a pedicle graft to bring in vascularization. If the perforation size is larger, one can do patch corneal graft, or at times they may require a tectonic therapeutic graft, or maybe at times more than a corneal graft, corneoscleral graft. So talking about the tissue adhesives, if the tissue adhesives are available in various, it could be synthetic, biological, or there are certain newer adhesives are also available, but commonest which is used in perforation is N-butyl 2 cyanoacrylate, which is a synthetic tissue adhesive. Biologicals, you all know, it is being used for sealing the tissue wounds, fibrin glue and all, and rest gelatin and thrombin, albumin, glutaraldehyde and polyethylene glycol polymers are the newer ones. So what should be the properties of an ideal tissue adhesive? It should allow a sufficient working time before inducing a firm adhesion. It should have an adequate tensile strength to maintain the tissue or wound integrity. It should be biocompatible as well. It should be clear enough to permit vision, but at least cyanoacrylate is not clear enough. Permeable to fluids and metabolites to prevent necrosis, and it must not induce inflammation. Must disappear eventually to permit healing at the interface, and does not carry the risk of transferring an infectious agent. It should be accessible and affordable. So when cyanoacrylate was first discovered by Coover and colleagues in 1942 interestingly in a Kodak research lab. Then in 1959 they reported unique adhesive property of this polymer and suggested its possible use for closure of surgical incisions. Since then the application of cyanoacrylate adhesive has become the initial treatment of choice for severe corneal thinning and perforations as a temporizing measure to provide a tectonic strength to the affected corneal tissue. So how does it work? The esters of cyanoacrylate exist as a monomers in a viscous liquid state. Upon application, the monomers are exposed to anions from the tissue, which triggers the polymerization reaction, and thus it promotes a binding to the tissue. So when we apply the cyanoacrylate tissue adhesive, it should be, the base glues have been used most widely in ophthalmic surgery. They need minimal hydration time to polymerize. It provides tectonic support. The tensile strength of the bonding is very high. It can only be used externally because it induces a lot of inflammation if it goes inside the anterior chamber or it comes in contact with the iris. It is used as an off-label to seal the perforation smaller than 2 millimeter in size. It can also be used prior to definitive management like patch corneal graft, if you end up seeing a patient with a corneal perforation and you are taking that patient for a surgical intervention, maybe you can apply cyanoacrylate tissue adhesive on table to form the chamber, and then one can go ahead with a corneal graft. The major drawback is that they form a solid mass which is impermeable to the fluids and metabolites and will persist as foreign body, causing inflammatory reaction like GPC or at times corneal neovascularization. So it has to be covered with a bandage contact lens. So what are the steps of like tissue adhesive applications? Commonest available cyanoacrylate with us is acrylate. It is available in the form of small ampule. You can use it, you can fill up the syringe, a small 1 ml syringe with this glue, and you can apply a 26 gauge needle so that you form a very small amount of drop at the needle tip. It's important to assess the area of thinning or perforation, apply a local anesthetic drops, maybe proparacaine, dry the area, remove necrotic material with a sponge or a Johnson bud, apply a small quantity of glue and allow it to polymerize completely. If the area is small, one can use a 26 gauge needle, or even one can use the back of the sponge handle. Like you can just put a small amount of tissue adhesive on that area and you can just touch that area to the corneal perf site. This can, if it is a very small and micro perforation, you can even use it as in-office procedure. You can do this procedure on the slit lamp if the patient is a little cooperative. Finally, cover that area with a bandage contact lens once it polymerizes and continue antimicrobials as needed and assess the patient on a regular intervals. This is a surgical procedure to show how it is being applied. It is important to dry that area carefully, and you have to remove the epithelium to allow the glue to sit on that area and have firm adhesions with the underlying stroma. So carefully, gently, because this is a perforated corneal ulcer, so you are gently, it is important to remove gently the epithelium. So you can see that a 15 number sharp blade is used to just lift up the epithelium and let that area be a little rougher so that the tissue adhesive can sit there very well. I am using a 26 needle mounted on a 1 cc syringe, and a liquid glue is applied, a very small amount. You form a little drop there, take away an excess amount and then just touch that area to that perforation site, and it would make a small nice film over that area. If you need, you can additionally add some more glue to allow that area to kind of seal, and then once it polymerizes, you can put a bandage contact lens. This is similarly another case where instead of a 15 number blade, I am using a dry Marocell sponge. If it is dry, you can definitely remove the epithelium with the help of the sponge because it is firm, and that creates a base for your tissue glue to sit there, as you can see here. In a similar manner, you can go ahead and put a small amount of cyanoacrylate. As you can see here, a very small amount, and excess amount is absorbed with the help of a Marocell sponge. So a small nice thin layer is formed. If the tissue glue is applied in a large quantity, sometimes there would be spikes formed, or there would be very irregular surface, and if the patient loses bandage contact lens, they can have bleeding from the eye, or the upper lid would have, the upper tarsal conjunctiva would have papillary reaction. So as you can see here in these pictures, a very small amount of glue was applied. The tissue started healing, as you can see here. Can you see the mouse, or this mouse is not functioning? Sometimes once the cornea starts healing, as you can see in the picture on your extreme right and bottom, the cornea is almost healed. If the cornea heals very well, then sometimes the glue would get dislodged. As you can see here, that the glue has dislodged and it is lying onto the conjunctival surface. So bandage contact lens also has been dislodged a little bit. So it can automatically also dislodge, or if you feel that the underlying corneal surface has healed very well, you can lift it up with the forceps and remove that on slit lamp as well. Sometimes if the perforation site is not very well covered, or at times it is loosely applied, you may require to have it more than one applications. But this would definitely invite a lot of vascularization, and it needs to be kept longer. Then we have to use, or we have to change the bandage contact lenses often. If the bandage contact lens is lost, patient may present with severe foreign body sensation and watering. So you have to explain that to patient beforehand. Too much glue up projection on the surface can lead to tarsal inflammation and papilla or bleeding, as I said earlier. If the base is necrotic, it can come off and it may lead to a larger perforated area also. So those are the problems which we can face. So in this retrospective analysis, it was found out that the cyanoacrylate tissue adhesive was moderately effective in restoring globe integrity in severe corneal thinning and perforation secondary to microbial keratitis in the short term. However, the majority of the patients required tectonic surgical intervention within 6 months. So every time it may not be sufficient enough to take care of the perforation, but definitely you can use it as a temporizing measure, and eventually you can plan a definitive procedure later. And if you are just a comprehensive ophthalmologist and dealing with these kind of cases, maybe probably, and if you don't have a corneal setup, maybe you can refer these patients after applying the glue and having the globe tectonically stable. We'll come to the next surgical procedure, that is use of Tennant's patch graft. Where do we use, if the perforation size is larger than 2 millimeter, where you cannot use a tissue adhesive, and if it is mild to moderate perforation, either with or without an iris prolapse, one can definitely consider using a Tennant's patch graft. People were earlier using even conjunctival graft, Gunderson flap, and many other options were there, but Tennant's works very well. So what are the advantages? It is available in abundance, so no dependency on any other donor tissue. Tennant's graft is harvested from the same eye and hence obvious need for any storage. As it is autologous tissue, does not need any immunosuppression. Ideally can be used for perforations of 3 to 5 millimeter in size. However, it has been used for perforations as large as 6 millimeter also. There are reported case series about that. In presence of inflammation, the tissue may disintegrate faster. So it is not an ideal option to use in a very fulminant infection. The mechanism of action would be the Tennant's layer acts initially by plugging the area of perforation. The tissue provides a scaffold over which the surrounding epithelium would gradually migrate, and once the epithelial continuity is achieved, the wound becomes watertight and the fibroblasts within the Tennant's layer may contribute towards the corneal scarring. Let's look at the surgical steps and the video. A small nick is made in the conjunctiva in the supranasal or supratemporal area, 2 millimeter behind the limbus, and the underlying Tennant's tissue is exposed. 1.5 to 2 millimeter is enough beyond the limbus, and then Tennant's tissue is dissected with conjunctival scissors. The size of the graft should always be at least 2 millimeter larger than the size of the perforation. Have a little larger amount of tissue than the size of the perforation. Any debris over the area of the perforation is cleaned. The excised graft is placed over the perforation and gently plugged into it. Either you can use a spatula or maybe a forceps or anything to plug it. I'll just take a minute to complete that.
Time, Paras,
Yeah,
you can
okay,
continue.
fine. I use iris spatula, or at times you can use even a tying forceps, not a very sharp instrument. Once the tissue is plugged into the perforation, you can use either box sutures or an overlay tenno nylon sutures which are applied in the pattern of infinity sign, where the suture should cross over the Tennant's area where you have plugged the Tennant's. In addition to that, one can even use a cyanoacrylate if it is needed, or even I prefer to use a fibrin glue along with a Tennant's so that the Tennant's tissue remains bounded together. Post-operatively, one can use topical steroids and antimicrobial coverage till the infection gets covered. This is a small video of the procedure. As you can see here, there is a perforation with an iris prolapse. What we are trying to do is we are trying to harvest the Tennant's. I have put a small incision into the conjunctiva and I have just taken out the Tennant's piece. Because there was, this perforation was sitting there for a little longer time, there was a little bit of, pseudocornea kind of a thing, which I have removed that epithelium. I have separated the synechiae with the help of iris spatula, and I am trying to stuff the Tennant's tissue into the perforation. Then I have applied both the components of fibrin glue so that the Tennant's tissue remains bounded together, and these are the infinity sutures with tenno nylon which you can apply externally to make sure that the crossing of the sutures is covering the area of the tenon's material, so that the perforation site, so that it stays there and over that area very constantly, and that area heals completely eventually. These are the post-op pictures. Like as you can see here, the last picture on your right hand side shows that the tenons has become flatter. Initially it would become edematous and then it becomes compact, and you can see that the AC is very well formed and sutures are still in place. So this was about 2 to 3 millimeter size of perforation, and where we have reposited the iris, done a synecholysis, put in an air bubble and stuffed the tissue into the perforation, and I have used a fibrin glue along with. This is another example of a perforated corneal ulcer with iris incarceration, which was on treatment for a month. He was a tanker driver. He had same history of similar attacks almost a year back. So possibly this was a viral infection with a secondary bacterial involvement. We planned for possible Chenon's patch graft with tarsorrhaphy, but we thought that probably because in presence of a lot of infection and inflammation, I just continued with systemic antivirals and thought that let me do a tarsorrhaphy and see how this patient is behaving. Systemic and topical antivirals and antibacterials to cover the management part. And you see that in the follow-up, we can see that the area is showing clearance and the vessels are running in, the area started showing healing, and this is how it started healing. So only a tarsorrhaphy also many a times can help in taking care of such ulcers. It's not necessary that every time we have to use a tissue adhesive or a Chenon's patch graft. Sometimes if this kind of presentation is there, even a tarsorrhaphy can help in healing these areas. This was another case, very interesting, like this patient presented like this with a large area of a corneal ulcer with a central perforation. You can see that the base is very necrotic. So this is not an ideal case for tissue adhesive as well as maybe probably a Chenon's patch graft. We just looked at the history and the other examination, and we realized that this patient had Hansen's disease, and that was missed initially, and probably that was the reason patient ended up with such a large ulcer. So because it was a very large ulcer, we had to do a therapeutic graft, but these are the cases where you have to add a tarsorrhaphy to that. If I would not have done a tarsorrhaphy, even this graft would have melted, because these are anesthetic corneas. So it is very important to recognize a systemic condition along with. This was another example of a case where there was a ring kind of infiltrate. This person was an agricultural person. He sustained an injury with a leaf, and we were able to just see some fungus onto the smears, but it was kind of unidentifiable fungus. It grew on the media as well. He was responding well, as you can see here in subsequent pictures, and we thought that he has really responded well, but eventually he ended up with a perforation. So it is very important to even taper your antifungals early on. If you just go on using your antifungals for a very long time, sometimes even toxicity of the antifungals also can lead to stromal melt, or at times even the toxicity of the organisms can lead to stromal melts. And these are the areas where you may not be able to apply a tissue adhesive for a very longer period of time. As you can see here, that there is a lot of necrosis around. So we went ahead and did a therapeutic graft for this patient. This was another young girl, 21-year-old young girl, who presented like this. She had a red eye and she was traveling, and she kept on using pyrimone eye drops, which is a common culprit, steroid and antibiotic combination, and she ended up with a large corneal ulcer and a perforation, and we saw her at this level, and we ended up with doing a therapeutic graft for these kind of ulcers. So you know that which are the cases where we can do a tissue adhesive application and which are the cases where we can use a Tenon's graft. So the take home points from this is tissue adhesive and Tenon's tissue are easily available. They are inexpensive tools for small perforations and for stromal melts in indicated cases if used judiciously. It does not require much surgical expertise and can be added to the management armamentarium very comfortably by anyone. Can be used, TA can be done even as an in-office procedure if it is a very small microperforation, and can be used as a temporizing procedure before referring the patient for further management to higher centers. However, larger perforations may need management in the form of therapeutic or tectonic corneal or corneoscleral graft. Thank you for your kind attention.
Thank you very much, Dr. Paras, for that excellent presentation. We'll have the discussion at the end. Now I invite Professor Vanati to present her talk on therapeutic keratoplasty. So we have identified the ulcers, bacterial, fungal or viral. We have done microbiological workup. When they perforated, we have done something to heal the perforation. Now, if nothing happens, then we have to do a therapeutic keratoplasty.
Thank you, Uma, for making me part of this nice and IC. I have no financial interest in the mention of any products or procedures during the course of my talk here. Over the next 10 minutes, I'll walk you through the surgical management in keratitis. This will be largely pertained towards fungal keratitis per se, but largely you will not see much differences, but I've kept it pertained to fungals because I'm going to highlight to you the recent aspects based on what we know about therapeutic keratoplasty in fungal keratitis on evidence based depending on all literature which we have with us. So when you look at fungal, you have at least 26 to 35% of fungal keratitis will require grafting in the acute stages here. And the problems with fungal is recurrence of infection, secondary glaucoma, graft rejections, and the functional success following a therapeutic keratoplasty. So these remain a pertinent aspect when we are doing therapeutic keratoplasty for our patients. And in India, largely, we do have a predominance of fungal keratitis in our patients here. So I largely do reserve my my therapeutic keratoplasties whenever the ulcer is chronic. So again, chronicity differs the way we are defining it, and chronicity differs about which region of the cornea is going to be affected. So we largely look at it when an ulcer is present for more than 3 weeks, and you're going to look at chronicity, and you would need a therapeutic keratoplasty to debulk the infective material from the ocular surface in these cases here. So therapeutic keratoplasty can be largely diagnostic. So if you're not able to get a microbial diagnosis, then you would probably need that tissue to be sent over to get a diagnostic of what etiological organism is causing the ulcer or the microbial status here. You would need it therapeutic when you need to debulk the ocular surface where it's been on the ocular surface for a long period of time and it's not responding to the medical management here. Again, prognostic. So prognosis is what you need to give when you're doing a therapeutic keratoplasty, and you're going to see how you're going to change the course of events on this surface which has become infected here. So I think Uma covered most of the diagnostic approaches, and Dr. Charu also detailed you how you would go about looking at the microbiological diagnosis of here. So this is a fantastic paper which talks about outcomes of therapeutic keratoplasty from a tertiary care center in northern India here. And therapeutic penetrating keratoplasty definitely has a role in managing both severe and refractory keratitis, and helps in restoring the tectonic integrity and the anatomical integrity here. The functional success depends upon the graft clarity, and that largely will depend upon the quality of tissue you're using and the morbidity of the case you're going to be dealing with, and in cases where your limbal and scleral involvement are also going to be present here. So that's going to dictate the outcome of your cases here. Again, fungal keratitis still remains the larger percentage of the cases which we do see here, and the prognosis is poor in your cases, and I think this largely also will apply to your bacterial cases. Whenever they are large ulcers, ulcer over 7 to 8 millimeters will have a bad prognosis here, and when those which have perforated early, so when you take them again, their outcomes are going to be less favorable vis-a-vis when you do it earlier on in these patients here. So looking at the predictors of corneal perforation for the need for therapeutic keratoplasty in severe fungal corneal ulcers, the depth of the infiltrate size and scar, your visual acuity, the presence of a hypopion are all significant factors which can influence the final outcome after you perform a therapeutic keratoplasty. So clinical examination at baseline is very important to identify those fungal ulcers which are going to need an early intervention here. I think I would not delve more into the theoretical aspects here, but whenever you have an involvement of the posterior third of the cornea, the risk of perforation is much higher and the need for therapeutic keratoplasty is again going to be is higher. So it's better on to do a therapeutic until without waiting for a perforation in these cases here. So per se it helps you to debulk, it helps to restore the anatomical integrity of the ocular surface, and it would, if you're successful in containing the infection with postoperative medications, meaning you have an early diagnosis and you also have your culture sensitivity and it is covering your organisms well, then you would also get a functional success in these cases. Yeah, I largely reserve my therapeutics to those more than 6 millimeters, impending perforations or perforated ulcers, and to establish the cause of the organism as well here. Again, when you're doing therapeutic keratoplasties, it can be a full thickness penetrating keratoplasty or it can be a lamellar. So when you are doing it for bacterial keratitis which are on their healing stages and your posterior one third or posterior half of your stroma is not involved, then you could probably consider a therapeutic deep anterior lamellar keratoplasties. This per se, probably you will have to be more careful if you're looking at acanthamoeba and you're looking at fungi. You will have to be absolutely sure that your antifungal therapy is containing the growth of the organisms, because you can never be sure that the posterior third is free of involvement, and perhaps a confocal, if possible, can help you to identify the depth of infections. Again, patch grafts, if they are small focal infections, small areas which are perforated, then you can look at a patch graft for these cases as well. Again, points to notice: have your diagnosis before you're delving in for surgery. The timing of surgery is going to be pertinent. So several times I see my residents that they find a case, they immediately admit and put it up for surgery. But I would always like to wait for 24 to 48 hours, that you take care of the ocular surface with the amount of fortified antibiotics here. So your medical therapy is maximal before you take them on for a surgical intervention. That always helps you to get a better outcome when you're better outcome in terms of controlling your infections when you are managing the patients. The approach to the surgical steps and the postoperative management are all important aspects when you're doing therapeutic keratoplasty here. So factors to be considered: microbiological diagnosis, indications for surgery here, and alternatives to therapeutic keratoplasty. So Paris nicely covered what are the various alternatives here. So that's when you probably will also need to know when you need to adopt alternative approaches and rather not do a therapeutic for this particular patients here. So I'll quickly move on to the surgical steps here. The first is the host trephination, the anterior chamber handling, donor trephination, management of other features in the anterior segment, the lens management here, and suturing concerns. So one by one, host trephination. This is a case we would always do the host trephination first here, and you ensure you give a free margin of the necrotic tissue here, measure your host window again, and then reconsider the donor trephination is adequately covering and adequately sizing. So this usually is a problem for those who are learning. They tend to downsize here and land up with a flat graft because of a tight suturing. So that's a problem which you need to be looking at here. Anterior chamber, several times you might find inflammatory membranes lining the iris, so that's something you need to take care of. Wash the anterior chamber angles here, because you might have infective material sitting there. Your lens, I largely would prefer not to handle your lens until and unless it's a total cataract which is sitting there, or an intumescent lens which you feel you need to remove, because that's going to compromise your anterior chamber depth after you've done your suturing here. Donor trephination, as I told you, needs to be adequate and of adequate size depending on the final host window diameter, and that is a that is something you need to take care of on your graft host sizing here. Lens management, again, do not take out your lens unless you really need to take them out here. Suturing is important, and for beginners, as I already pointed out, do not do not land up doing flat tight suturing, and then you would have a problem in these cases. So this is here you could see this is a case where the central cornea has become very necrotic. It is already thinned out and it is perforated in perforated in the central region here. It's a flat anterior chamber which you are having in the beginning. So general anesthesia is always desirable for these cases here, and would not attempt to give a block here. But in dire cases, if you do need to give a block, a facial block as well helps you, so that it gives you more comfort when you are managing these cases here. So measure the region, and a handheld to find to delineate the region which needs to be find out. And in this particular case, I was lucky to get a good trepanation, partial trepanation, and then complete it. So you can see there are some pupillary membranes here, and if they are there, then they need to be removed. And a good quality donor tissue is always helps if you find those cases which are going to have an optical result here, and then go ahead and complete your suturing and form your AC here. I per se tend to do my therapeutics with lesser use of viscoelastic, so that's something I always like, the lesser viscoelastic, and I keep reforming my AC with BSS and with saline. That also decreases your inflammation quotient in the postoperative period, and the IOP pressure quotient as well in these patients here. So, this is just one of the case. And then moving on to certain aspects of adoption of therapeutic DALK for our patients. That's when your anterior chamber imaging largely helps you to look at the involvement of the posterior stroma, and when the posterior stroma is largely clear, you can go ahead and do a lamellar keratoplasty. So therapeutic DALKs for these patients, it will be manual DALKs, and you can create create the lamellar graft to the desired depth, depending upon the amount of tissue which you are removing. These give you fantastic results here, and they also help you in good visual rehabilitation of taking the patient up to 618 or so, because the residual stroma does have some amount of opacity, or it's not that transparent when you do it. But that's another alternative when you like to contain your infections. But you will need to look at and select your cases very carefully in these patients. And in the term of recurrence, you can probably just pull out the graft and then replace the grafts in such patients here. So this is just to close with a very rare appearance of a primary corneal acrimonial eumycetoma, which looked like an anterior staphyloма, which we did when we first saw it, and we had to take this patient in for a therapeutic keratoplasty at the end for this patient. I think I will close here, and we will take questions if we have any. Thank you.
Thank you for that excellent talk, Dr. Vanati. Now I would invite Dr. Jyoti Batra to tell us what to do on post-operative follow-up of therapeutic ulcers. This is extremely important in, like Dr. Vanati said, in fungal ulcers. When will you start your topical steroids? And what to do when you see a patient in your general OPD which has been referred to you, or you want to refer forwards after follow-up of therapeutic keratoplasty.
Reinfection or recurrence of the graft as well as the host edge. The secondary objectives are to promote epithelialization, to control the inflammation, and to closely monitor and manage the raised IOP. So if we talk about the clinical outcome in cases of therapeutic keratoplasty, what is more important is the anatomical success and the therapeutic success. The restoration of the tectonic integrity of the globe, and if we are able to completely eradicate the infection, our therapeutic keratoplasty is said to be has a successful outcome. Functional success, as far as the visual outcome is concerned, it is desirable, but it is not the primary aim as far as the therapeutic keratoplasty is concerned. In the postoperative management, the continued use of the antimicrobial is the mainstay therapy for preventing the recurrence of infection. So if we talk about the topical as well as the systemic, both antimicrobials are important in the post-operative management. The corticosteroids, the use of corticosteroids, whether to use it in the early phase or not to use it, and what is the timing at which and what amount of dose and concentration is a very critical decision that has to be made. It depends on the various factors which we are dealing with when we've done a therapeutic keratoplasty. And equally important is the closer and regular follow-up of these patients. That can be a major determining factor for the success of the therapeutic keratoplasty. So if we talk about the topical antimicrobials, and if the surgery has been done for a bacterial keratitis, it is important to use the antibiotics with most sensitivity on a frequent basis till the epithelium heals. And if suppose the sensitivity is not known and the offending organism is not known, in those cases the combination therapy is given or a broad spectrum antibiotic is added. Till the further treatment is guided by the histopathology and the microbiology report of the excised cornea, which we've sent to the microbiologist. So as far as the topical antifungals are concerned, when we are dealing with the fungal keratitis and have done a keratoplasty in such cases, they also have to be used in frequently till not only till the epithelium heals, they have to be gradually tapered and sometimes have to be used over a period of 2 to 3 months. Similarly, when we are dealing with acanthamoeba keratitis, in those cases also the extended use of these topical amebicide drugs has to be used, which has to be continued even till a period of 6 to 12 months. And as far as the viral keratitis, if suppose we've done the surgery for the viral infections, in these cases it is desirable not to use topical antiviral agents in the immediate post-operative period because they are epitheliotoxic. So what it's better to use systemic antiviral therapy, and these topical antiviral therapies do not add any additional advantage as far as the prevention of the recurrence is concerned. Now coming to the systemic antimicrobials have a definitive role as far as the management, the post-op therapeutic management is concerned, as compared to when we are dealing with corneal ulcers, where the topical management, topical drug therapy is the mainstay. When we've done a therapeutic keratoplasty, in these cases, systemic antimicrobial is to be continued, especially when we are dealing with bacterial, fungal or viral keratitis. So in bacterial keratitis, they have to be started before the surgery and to continue at least for a week post-surgery. And when suppose we've done the surgery for the fungal keratitis, in those cases it has to be continued for at least 2 weeks post-surgery, and the use of these the oral antifungals has to be extended for a period of 2 to 3 months also. If suppose at the time of the diagnosis the ulcer was perforated, there was a hypopyon or a lens involvement, or there is a limbal involvement. But what is important to remember when we are dealing with the fungal when we are giving oral antifungals to the patient, is to monitor their liver function test, and especially if we are using it for a prolonged duration. Similarly, when we've done surgery for viral keratitis, in those cases, oral acyclovir in the therapeutic dose has to be given for at least a week, and then the prophylactic dose of 400 milligram BD has to be given at least for a period of 6 months. It can be extended to 12 months if required. Oral valcyclovir is a good viable option, alternative to the acyclovir, because acyclovir is directly gastrotoxic. So it has the same efficacy with minus the side effects. So as far as the topical steroids, the use of topical steroids in the post-therapeutic keratoplasty is concerned, It's a very, very important decision which should be judiciously taken, because the main aim is to remove the infection. But yes, the inflammation equally is responsible for the failure of the graft. Topical steroids not only control the inflammation, they prevent the formation of the peripheral interior synechiae in these cases, and also prevents the extensive corneal vascularization that can take place. So, if the organism is known and the epithelium has healed post surgery, the topical steroids can be given in the early phase. Similarly, in the viral keratitis, if the patient has been given systemic oral antivirals, in these cases, it has to be given from the start post-operatively. So, in fungal keratitis, even if the epithelium heals and the epithelium heals and there are no sign of infection, it's better to withhold the use of topical steroids for at least 2 to 3 weeks after the surgery. Acanthamoeba also, you have to be very, very judicious whenever you're using the steroids. So, systemic steroids have to be used only when there is intense inflammation and scleral involvement, in very, very select cases. Cycloplegics to prevent ciliary spasm. It's important to monitor the intraocular pressure on each visit post-operatively, and to add IOP lowering agents to take care of the glaucoma. To take care of the elevated IOP or glaucoma, because the persistent IOP rise post-surgery can damage the optic nerve permanently. So, it's important that you add an anti-glaucoma drug whenever it is required, and it's important to consider to know that the prostaglandin analogues and pilocarpine has to be avoided as a first-line therapy in these cases, because they also increase the inflammation, and we've done the surgery in the setting of the inflammation. So, artificial tears also, because there is associated epitheliopathy and they can be persistent defect in these cases. So, artificial tears have to be added in such cases. Better to use non-preserved artificial tears. In the post-operative follow-up, it's the most important part is to closely monitor and see for any signs of infection, especially if you've done a lamellar therapeutic keratoplasty. The interface is one area where you should intently look for it. The graft-host junction, the host rim, and any in the area of a defect. These are the basic areas where the infection is more likely to be there. So you should closely monitor those areas. And apart from that, it's important to identify wound leak. Simple fluorescent test would identify that leak, and that the patient can be taken to a OR for the resuturing. The epithelialization is important, because a persistent epithelial defect can is a predisposing factor for as far as the infection. Can I take 2 minutes? So, persistent epithelial defect is a ground for reinfection. So, it has been shown that the fungal etiology, retroiris exudate, coexist in endophthalmitis, and larger grafts are susceptible to recurrence. So, and timely intervention can mitigate these factors. So, if we talk about the recurrence, so it's important, as Vanati ma'am was discussing the lamellar keratitis, therapeutic keratoplasty. So this, if suppose the interface has to be looked in intently on each visit, if we've done a therapeutic keratoplasty, here we can see a grayish white infiltration in the interface, which was treated with the penetrating keratoplasty. Similarly, the graft host junction, here you can see a gray white infiltration where the affected infected rim is excised, and then medical treatment is continued. In this case, you can see that there's a infection, the recurrence of the infection in the host rim, where it could not be managed topically with the topical antimicrobial therapy. Here, the patch PK has been done to contain the infection. So the epithelial integrity is also very important. So better to avoid epitheliotoxic drugs, and whenever in situation nothing works, the tarsorrhaphy comes in handy, and it helps in these situations. Punctal plugs and amniotic membrane transplant are also useful adjunct as far as the epithelial integrity is concerned. So to control inflammation, we've already discussed that corticosteroids can be more liberally given if we can be more sure of giving topical corticosteroids in patients where we've done the surgery for the bacterial keratitis, vis-a-vis when we've done the surgery for fungal or acanthamoeba infection. So secondary glaucoma is also one thing which we should definitely look in for. The inflammation, the hyphema, the pupillary block, and in the large grafts, compression of sutures, distorting the anterior chamber. These are the main reasons which can lead to IOP rise. And in the late post-operative period, the peripheral anterior synecdoche can also lead to a persistent rise of the treatment. Sometimes when, despite the maximum medical therapy, the IOP rise is not controlled. In those cases, secondary surgical intervention has to be taken, the TSCPC or trabeculectomy or a glaucoma implant after discussing with your glaucoma surgeon. So if suppose the patient has the graft size has been more than 10 mm, there are more chances of persistent epithelial defect, reinfection, and graft melt. So in the early post-operative period, it's important to look in for loose sutures, suture infiltrate if there is any. Just a minute. So suture infiltrate, then we have to remove the suture. If there is a suture infiltrate, it has to be removed and has to be plated on the bladder car. If there is a setting of a flat AC with flat or a shallow AC with the anterior chamber leak with the IOP low, that is a setting. Basically, it can be because of a wound. If there is a flat AC with a decreased IOP, that can be because of the anterior chamber leak, and it needs to be resutured. Persistent epithelial defect can be treated with the tarsorrhaphy or punctal plugs or amniotic membrane. In the late post-operative periods, what is important is to take care of the glaucoma part of it. Even if the graft fails, but if there is no extensive vascularization on the cornea, the anterior chamber architecture is maintained, and the IOP is under control, that is a good ground for future repeat keratoplasty or a DSEC or DMAC in the future for the final visual outcome for the patients. So as far as the final outcome is concerned, it is more encouraging as far as the bacterial keratitis as well as the viral keratitis. Now with the the timely management or timely intervention in fungal keratitis, it has been shown that the clarity as well as the cure rate in fungal outcome is also encouraging. Thank you.
Thank you, Dr. Jyoti. I just have one question for each of the panelists. Dr. Paras, when would you use systemic medication in case of bacterial keratitis and fungal keratitis? And Dr. Vanati, what would be your post-operative regimen for fungal keratitis? So first, Dr. Paras. Yeah, sure.
Sorry, you said bacterial and?
Fungal keratitis, when would you use systemic, oral antifungal or antibacterial?
If the fungal ulcer is not responding to topical, by and large, I don't use systemic antifungals for all the patients. But if the fungal ulcer is not responding, or if there are a lot of exudates, endoexudates also, probably I would like to add systemic antifungals to that. For bacterial ulcers, usually I don't start systemic antibacterial.
Often seen that practitioners, they give all the antibacterials 4 times a day, 5 times a day, antifungal 4-5 times a day. So it is important.
If the antifungals, if the antimicrobial dose is used in a proper fashion, probably the systemic management is not required. Instead of giving, those homeopathic doses, it should be 1 hourly daytime and too early at night or something like that, depending on the severity of the ulcer. You can decide the dosage, but sometimes you can even add a loading dose. If you are dealing with a bacterial ulcer, a loading dose can be given every 5 minutes, drop for first 30 minutes, and then every hourly. That loads the tissue with the antimicrobial agent, and then it is easier to maintain that concentration into the tissue. So that is very important, not to use the medications in just QID or TID dosage when you are treating or dealing with a corneal infection.
That is an extremely important message, take-home message from here, that 1 hourly during the day and 2 hourly at night for antibacterial and antifungal is extremely important. Don't worry about the drug toxicity, manage that, but your first step is to heal the infection. The next, Dr. Vanati.
I agree with Dr. Paris here that we routinely do not give systemic antibiotics or antifungals for our cases. So indications for systemic therapy would be when you're dealing with extremes of ages. You're looking at pediatric cases, or you're looking at elderly patients here. You're looking at one-eyed patients with vision access threatening for loss of vision here. And if you're having posterior segment infections, if you're having an endophthalmitis in those patients, those are the conditions, and in immunocompromised individuals. So these will be the particular scenarios where you would want to consider a systemic antimicrobial therapy. Apart from which, if your topical medications are given in the right dosage and the right concentration, so here is when you would not probably consider monotherapy, but you would look at fortified antimicrobial therapy. One other aspect I use is if you're looking at a VER in patients with chronicity, and if you find your VER is dropping, your visual evoked response, which means there is a toxic aspect where your optic nerve head is also getting involved. So that is something which I always advise my residents to look on in chronic cases here. So that's something which helps you for an early intervention, and you probably would want to consider a systemic therapy in such cases as well.
Thank you all. Thank you, audience, for attending our IC. Now I conclude our IC, and we'll have a photo in there. Thank you.